is Edwina Rogers, the Executive Director for the Patient-Centered Primary Care Collaborative. And thank you for joining us today for our general briefing on the implementation programs that are going on around the country on patient-centered medical home and the rest of our overview that we have planned for you today. You should be, for the folks that are joining us through their computer with the webinar, you should see a question box. So as questions come to you while I'm speaking, go ahead and just type them in, and then at the end there will be plenty of time for us to go over all the questions and give the answers. We usually just do this orally, but we're doing it this month through a webinar so that we can save it on our website, which we like to do every quarter or so. So we'll go ahead and get started here. You will see the slide change in front of you in just a second with regard to the agenda that we will be going over. Okay, here we are. So we'll talk about the National Pilot Activity Overview. We'll give an overview of the Patient-Centered Primary Care Collaborative. We will also define patient-centered medical home and accountable care organizations. We will look at some of the evidence on the quality improvements and the cost savings for patient-centered medical homes. We will look at recognition programs for patient-centered medical homes, Trust but Verify, and then we will move into the federal initiatives, what the federal government is doing with regard to implementing patient-centered medical home and ACOs, and we'll go over the provisions that we received in the healthcare reform legislation, and then we'll wrap up by looking at the resources that are publicly available to the community concerning all the topics around healthcare delivery system reform and, in particular, medical home and accountable care organizations. So that's an overview of what we'll be going over today. So moving on to slide number 3, this is a picture of a map that is on our website. It's an interactive map that you can go to and look at activity in particular states. Of course, we're tracking all types of activity. There are employers implementing it, health plans, Medicaid programs, CHIP programs, large multi-stakeholder implementation programs. So we're particularly interested in the larger multi-stakeholder ones because the whole community benefits. So you can see here where the majority of those are listed. We have tracked that 44 states, including the District of Columbia, have passed over 330 laws requiring patient-centered medical homes either in their Medicaid or in their CHIP program. Looks like we jumped a slide there, so I'm trying to go back to the slide that is skipped. So slide number 4 has to do with, this is an example of health plan implementation. This happens to be Blue Cross Blue Shield. You can see where the red houses are. They're working on multi-stakeholder implementation. The other colors are their single health plan implementation programs. Not just Blue Cross, there are plenty of other all the national health plans and many of the community and regional health plans are also implementing medical home within their plan. You can see slide number 6 shows you the states that have a significant health plan activity going on in those states concerning patient-centered medical home. And then moving on to slide number 7, this shows you the states that have commercial pilot activity concerning Medicare Advantage, and we'll cover in just a minute the activity that's going on in Medicare. Slide number 8 is in front of you now. There are approximately 40 states that are working on implementing medical homes in their Medicaid or their CHIP programs. You can see them there. Slide number 9 that I'm moving on to shows you a combination of commercial Medicaid, CHIP, and Medicare fee-for-service implementation. Those are the red states, which I'm going to move on to slide number 10, and we'll talk about those for a moment. In November of 2010, 8 states were selected to have access to Medicare for implementation of patient-centered medical home. And then slide number 11 is showing you, I mean, basically those states are mainly in the Northeast, plus North Carolina, Michigan, and Minnesota. This particular slide, slide number 11, is showing you the states that have significant implementation programs in them, and we don't have anything going on in Montana, although you can see Alaska over to the left, and they're starting to implement medical home within the state of Alaska, just getting started there. Moving on to slide number 12. Slide number 12 is showing you with regard to what do we do to track pilots. We, in the past, you can see the proof in practice guide there on the left. In the past, we would do a national survey in August and September and produce a guide toolkit in October or November called Proof in Practice that gives you the details of pilot activity, like who's at the table, who the stakeholders are, how many physicians, how many patients, the HEDIS measures that they're tracking, the payment model that they're using. But we now do that on our website. We still have these guides that are more than a year old and 2 years old, but the activity is being updated weekly on our website. You can see how it looks there and go to it and check for activity going on in your state. Now, moving on to slide number 13, we're going to start talking about the Patient-Centered Primary Care Collaborative and why it's important. We are the national convener on healthcare delivery system reform, in particular patient-centered medical home and accountable care organizations. We do the legislative and regulatory advocacy, mainly at the federal level, but some at the state level also. And then we spend most of our time at this point in the implementation of healthcare delivery system reform, sorting out the white space policy around PCMH and ACO. So we're developing the policy through guides, toolkits, white papers, content for website, PowerPoint, pulling together stakeholders. There are more than 750 publicly signing members out of a class of about 3,000 participant members. We have 62 executive committee members. We do all types of monthly calls and webinars, and we have a national call every Thursday at 11 o'clock with an agenda or newsletter where we just go over what the centers are doing, the task forces, any conference that any group is having on patient-centered medical home or ACOs, what the press is saying, etc. And so if you just sign up on our website, then you'll have access to that and get that agenda. And it's run by our COO, Amy Gibson, every Thursday at 11. The number was on the last slide. Okay, so moving on to slide number 14, basically the collaborative was initially created by about 35 Fortune 500 companies that have employees in every zip code around the U.S. and many around the world, you know, like FedEx and Exxon and IBM. And they started to notice that where they had employees in an area, if there was something similar to the medical home model or some type of advanced primary care model, that their costs were lower and their quality outcomes were higher. So they came to Washington, wanted to work on implementation nationally for patient-centered medical home, started working directly with the providers that could provide this type of service. And then we spent a lot of time working with patient and advocacy groups. We have about 160 of those involved at this time. You can see some of them: AARP, SEIU, AFL-CIO, American Diabetes Association, and then all the national payers joined about a year later. So that was September 2006 when it got started. So moving on to our next slide here, you can see this is a bit of our organizational chart. We talked about the general membership. We have the 6 centers down at the bottom, all kinds of task forces that are trying to sort out everything from integrating behavioral health into the medical home and bringing the medical home to people with more substantial behavioral health issues, medication management, a task force on education and training, care coordination, practice transformation, payment reform, technology, usability, meaningful use, the technology that you would need for accountable care organizations. And these are others. It's just giving you some examples. You know, at any given point in time, there are probably about 10 to 14 task forces operating in our centers. Now, the next slide is going to talk more about our centers where most of the action is housed. And so we have 6 centers. The first one is a Center for Multi-Stakeholder Demonstration, that nurturing pilots, helping them get started, tracking pilots, helping them with antitrust issues, best practices, standing, extending, funding sources, etc., and of course evaluation. Our second center is the Center to Promote Public Payer Implementation, that has to do with started originally with the state Medicaid directors and has been now included folks from Defense that's working on a full implementation program for 9 million people, veterans, about another 5 million people, the Office of Personnel Management, working on implementing medical home for all the federal employees, of course HRSA, working on implementing medical home for the federally funded community health centers, and then of course all the activity in Medicaid, and then what Medicare has going on through the Innovation Center and the Advanced Primary Care Demonstration Project for the 8 states. And the list goes on. So that's where you find the public payers at the state level and the federal level. Center for Employer Engagement basically goes back to the core, the beginning, and that's where you would find employers of all sizes. They have special needs and interests. They have a value-based insurance design guide. They have a guide that outlines measures and metrics that employers are particularly interested in, like absenteeism and presenteeism. They have a purchaser guide. We have model letters that employers can use in explaining this concept to their employees and helping to recruit them to medical homes. We have the Center for eHealth Information Adoption Exchange, and that center is looking after all the IT side that's required in the medical home, so everything from meaningful use to decision support tools, IT to increase participatory engagement, IT that you need for an ACO. And we have the Center for Consumer Engagement, that is making sure that the consumer stays at the center of the medical home practice implementation and then also at the patent implementation. We have the new Center for Accountable Care that is sorting out the whole medical neighborhood and has 4 new task forces. But we'll be talking about all of this a little more in detail. So moving on to the next slide, slide number 17 has to do with trying to get it to move here. There it is. Okay, so 17 has a little bit of the history of the medical home concept. It was created in 1967 by the American Academy of Pediatrics for children with special health care needs. So since it has been around for quite a while, we of course wanted to keep that history and that name, update it by taking the definition of patient-centeredness from the Institute of Medicine and wrapping it around it. We're on Twitter and Facebook and Wikipedia. Okay, so the next slide has to do with the joint principles that were put together by the 4 primary care physician groups concerning patient-centered medical home. This was February 2007. These joint principles defining the medical home for the primary care physicians also has been endorsed by more than 18 specialty physician groups, including the American Medical Association. We're going to move on to slide number 20, which is probably pretty much our most important slide that you will see today. So we're going to define the medical home. So after this, you'll have a very good feel for what we're talking about. There are 7 categories within the medical home. 3 of them are extremely important and very much required. One is the access piece, the clinical information systems, which is the IT, and the care coordination. So let's go through the 7. So on the access side, you will find things like it's easy to make appointments. You have same-day appointments, waiting times are short. You'll have e-visits, phone visits, extended hours, 24-hour call center. If you don't have access, it isn't going to work very well. Then you have to engage the patient in their care. So they're informed, they're partners, they're given treatment plans, preventative follow-up reminders, access to their medical records, assistance with self-care and counseling. It's the clinical information systems that the primary care provider has to have in place. They support high-quality care, practice-based learning, and quality improvement. They have to maintain practice registries, patient registries. They have to monitor adherence to the treatment plan, have easy access to labs and test results, receive reminders, decision support, and information on recommended treatment. And then moving on to care coordination. So this is is basically the core piece of the medical home concept, where the primary care provider agrees to step up to the plate and take responsibility for the mental health and the physical health of their patient and coordinate their care throughout the system. Now, moving on to the team care approach, that's where the primary care provider is responsible for assembling the team. You might have one patient that obviously needs a behavioral health expert on their team, and then maybe the next patient needs a cardiologist and a dietitian on the team. So it would be the responsibility of the medical home to assemble that team. Of course, most of the time it would be a virtual team. Patient feedback, a certain percentage of the patient population would be surveyed, 4 or 5% to get the patient experience. And then the last category, the publicly available information, that is the quality and the efficiency information of the medical home, so you can see the value for the dollar. Moving on to our next slide, which is slide number 21. This slide has to do with the medical home is the foundation of any accountable care organization. Let's look at the definition of an ACO. Basically, the Institute of Medicine defines it as a group of providers that has a legal structure to receive and distribute incentive payments to the participating providers. So if you think about the U.S. market, you currently have roughly about 20% in integrated systems, and you have about 80% that's not. So just going over the definition of the medical home, you can see why you can get very good accountability, you can get some cost savings, you can get quality improvements. But these days, that's not enough. We need accountability from the whole healthcare system. So moving on into the medical neighborhood and having an accountable care organization that's founded in the medical home, once you include specialists, the hospital, pharmacy, everybody else, you should be able to squeeze out additional accountability, like, for example, with readmission rates for hospital admissions. Now, think about how are you going to create an ACO. So the majority of them will probably be, virtual ACOs. They'll have compact agreements between hospitals and specialists and primary care physicians in particular, so that they'll have the right to share these incentive payments. So in exchange for all of this that we're talking about, there has to be payment reform, of course. So slide number 22 is showing you the general payment model that you will find for patient-centered medical home. So there's a monthly care coordination fee per patient per month, slightly risk-adjusted. Sometimes I've seen age, I've seen number of conditions, etc. Several ways to do that. You have the traditional office visits on top of that. You have pay-for-performance payments on top of that. Okay, moving on to slide number 23. This is generally the current state of the payment system in the United States, where you have most of the money coming from fee-for-service. And the next slide is going to show you more along the lines of where we're trying to get to, where you start seeing more of the payments come in through the care coordination fee and the pay-for-performance, and then moving on to the ACO shared incentive medical neighborhood payment model. Now, you're probably wondering at this point, the care coordination fees, the monthly care coordination fees, how do they look? What are the ranges? So we've got some examples here. I pulled 5. It's a little bit tricky. We have some additional guides in depth on our website, and I'll show you some of those a little bit later on, that give you the details on the payment model. Now, there are the cash payments, the monthly care coordination cash payments, but then a lot of times you'll also see some in-kind back office services that are being offered, perhaps access to caseworkers or medication management, or paying for your recognition program, etc. So you can see here there's the Maryland Patient-Centered Medical Home model. You can see the range is based on the size of the practice and their level of medical homeness. They're using the NCQA model there, level 1, 2, and 3. Right below that is the Minnesota Healthcare Homes. That is in the kind of $10 range up to the $60 range per patient per month. That has to do kind of based on an estimate for minutes of work. So look at condition and age and things of that nature. So Minnesota Medicaid is one of the obviously higher paying medical home models for the Medicaid program. Okay, we're going to move on to slide number 26. And we have the New York Capital District Health Plan model here. We also have, doesn't want to change it too quickly sometimes and then not quick enough other times. The slides do. So we have New York Emblem Health. You can see moving down to Pennsylvania Chronic Care Initiative. They have some initial payments that they make based on sort of, ramping up, and then other payments based on age. So that gives you a feel for the monthly care coordination fees. And I've seen them in, low as $1.50 or $2 up to a high of about $100 per patient per month for more complex patients. Now, moving on to slide number 27, there's a body of research that is extremely important here with what we're talking about that I don't think is very well known. Like, for example, Barbara Starfeld with Johns Hopkins has shown that adults with a primary care physician rather than those that just use specialists had a 33% lower cost of care and were 19% less likely to die. The Commonwealth Fund has done a lot of research in the medical home arena, and their research shows that it can reduce or even eliminate racial and ethnic disparities in access and quality for insured persons under the medical home model. Now, Denmark is a country that has organized their entire healthcare system around patient-centered medical home. They have the highest patient satisfaction ratings in the world at 98%, and they're among the lowest per capita health expenditures, and they have the highest primary care ranking in the world. So let's look at some of the evidence on the quality improvement side and the cost savings side. We've got roughly about 60 implementation programs that have reported some type of results, and we'll run through a variety of those in the next few minutes. So if you look here at Group Health Cooperative of Puget Sound, they had 29% reduction in ER visits, 16% reduction in hospital admissions, and they had reduced costs. Geisinger Health System, they had 18% decrease in hospital admissions, improvements in diabetes and heart disease care. They had 7% reduction in costs. And so maybe you're wondering, well, why did I just mention diabetes and heart disease care? Because that's all we have room for today in this short PowerPoint in this short time period. But we have publications, of course, that go into details on all the HEDIS measures and the disease states that are being tracked in the implementation program. Put Geisinger in so that you can see that it works well in an HMO also. Moving on to slide number 29, which goes over the Veterans Health Administration, the improvements that they have had there. They had improved chronic disease treatments, 27% reduction in ER visits and hospitalizations, lower median costs for veterans with chronic conditions, $4,491 versus $5,084. Health Partners Medical Group, Minnesota, 39% decrease in ER visits, 24% decrease in hospital admissions, and they had approximately about an 8% cost reduction. The highest cost reduction I have heard of so far, as far as percentage-wise, is coming from Boeing out of Washington State. They're reporting 20% cost reduction. Okay, moving on to slide number 30, we have Intermountain Health Medical Group Care. The Management Plus, they had 39% decrease in emergency room admissions, 24% decrease in hospital admissions. They had a net reduction of cost of $640 per patient and $1,650 among their highest risk patients. Blue Cross Blue Shield of South Carolina, they had 12.4% decrease in ER visits, 10% decrease in hospital admissions. They had an overall decrease in their total cost of 6.5%. Moving on to slide number 31, we have the Medicaid program for in North Carolina and also Colorado that we're talking about here. In North Carolina, they had cumulative $974 million savings over 6 years and 16% lower ER visits. Colorado shows that children's annual median cost was $2,275 compared to those that weren't enrolled in the medical home at $3,404. And we have some miscellaneous programs here that we tried to squeeze in, just a couple more. But I want to show you slide number 32 here for a minute. So basically the cost savings are just simple cost avoidance. It's not, going to any provider group and saying, oh, we're going to pay you less, reimburse you less because we want to pay these medical homes more. But it just works out. This is North Carolina. This was put together by Mercer. Fiscal year 04, this is their Medicaid program, about 750,000 recipients and in the state at that time. And you can see that inpatient overall for the state went down 142 million, outpatient 51 million, emergency room 25 million, all the physicians in the state down 45 million. The primary care, the average primary care physician at that time, they were paying $2.50 per patient per month, saw about a $20,000 net increase, and the pharmacy spend went up. Overall savings of $244 million. We did hear from the Pennsylvania people that they're expecting the primary state to go up by 80,000. In Rhode Island, the highest number I've heard it at 120,000. Now, moving on to slide number 33, Trust But Verify. There are recognition programs for the medical home model. I would say about half the Medicaid programs have developed their own. The other half are using NCQA, to my knowledge. URAC has a medical home toolkit that came out in October of November of last fall. And then the Joint Commission, they're coming out with a medical home recognition program, I believe, on July the 1st. They're also all starting to look at the ACOs. Now, CARF is looking at recognition for other providers, other than the primary care provider, behavioral health, etc. And then there's the Accreditation Association for Ambulatory Health Care that has a medical home certification program. Now let's talk about roughly, how many medical homes are there in the U.S., how many clinicians. By our calculation, there are approximately about 40,000 already that have been recognized. This slide here shows you 9,329 of them because they're in the NCQA program, and they were kind enough to loan us this slide here so you can see the states that have the majority of the recognition program through this particular recognition company, NCQA. Now we're going to move on for our last few slides here, and we'll be able to wrap it up and get to our questions here. I hope people are typing them in. So slide number 35, what is the federal government doing with regard to patients that are in medical homes? So we know that Veterans is working on a full implementation program, and that is for about 5 million people. The Department of Defense is working on a full implementation program, which is very exciting. That would be for about 9 million people. AHRQ has done a lot of research in the medical home arena. They have a researcher's portal with all kinds of journal articles, and they have put together white papers and toolkits on a number of issues. SAMHSA is very interested in bringing medical homes to people with behavioral health issues, and then also integrating behavioral health into the medical home. CDC is focused on prevention, and medical homes doing a really good job with prevention. Office of Personnel Management is rolling out a program to bring medical homes to all the federal employees. Now, slide number 36 is talking about the Medicare Advanced Primary Care Demonstration Project, where 8 lucky states, because they were doing a good job with their implementation on the private sector side and the public sector side in Medicaid, mainly got access to, it looks like I forgot to change slides, but you did it for me. Thank you. So we have the Advanced Primary Care Demonstration Project. The lucky states are Maine, Vermont, Rhode Island, New York, Pennsylvania, North Carolina, Minnesota, and Michigan. So they have access to Medicare. North Carolina had filed a 646 waiver, and the Congressional Budget Office had done some research and estimated that in North Carolina alone that there should be about $1.4 billion worth of cost savings over a 5-year period for Medicare for North Carolina. And so now they're in the Advanced Primary Care Demonstration Project. The Innovation Center has been charged with implementing the medical home throughout the rest of Medicare, and so they're getting ramped up, and we're working closely with them on that particular project. And then, of course, we're working on the Accountable Care organization regulations. They will release April the 1st, and we'll get our comments in like everybody else by June the 6th. Now, moving on to slide number 37, and just about the Innovation Center, they have the right that has already been given to them to implement the medical home in Medicare throughout all of Medicare if it is proven to reduce costs or it improves quality without increasing costs. They don't have to go back to Congress for any permission there, and then they do have to work on the medical home for the legislation. So slide number 37 talks about some of the changes that we got in healthcare reform that promote primary care, the medical home, and ACOs. So they fall into three categories: more money for workforce supply and training to help support medical homes, of course, more money for pilots and implementation programs in Medicaid. We talked about Medicare, with mainly the Innovation Center being in charge of implementing patient-centered medical homes throughout Medicare. And then there was general payment reform, like, for example, the Medicaid payments will be at the minimum the Medicare level for fiscal years 2013 and 2014 for primary care services only. And then also in Medicare, there's a 10% bonus for patient-centered medical home, well, for primary care services, basically, for all primary care services. There's a 10% bonus beginning in 2011, and that runs for 5 years. The Medicaid program paying at the minimum the Medicare level was a $5 billion ticket item. There were other provisions that we were able to get, like, for example, grant money for shared decision-making in the medical home, medication management in the medical home, a primary care extension program for training primary care physicians on the medical home. And then we will move on to slide number 38 and look at some of the resources that we have available. We have a guide on best practices for diabetes and the medical home, just using diabetes as a case study, employer metrics, so some of the measures that employers are particularly interested in, like absenteeism, presenteeism, with the Better to Best consensus report, and that details how medical homes work with accountable care organizations and are the foundation. We have a detailed payment rate brief that talks about those monthly care coordination fees and some of the back office services. We have a value-based insurance design guide that employers are particularly interested in. We have an IT guide on how to put together your IT for a medical home. And we've got 20 case studies in there. We have a purchaser guide for purchasers of health insurance for their employees. We've got model language there that you can use, like RFP language with the third-party administrator, health plan, a lot of research and case studies on why it's important to get medical homes for your employees. Payment reform guide, very popular, all the details on the payment model, clinical decision support tools that the medical home needs to have in place, the pilot guide, consumer guide has a lot of good advice and information there for practices and also for implementation programs and pilots on how to include the consumer, the patient, and the family. Medication management guide, very popular. Participatory engagement guide, how to activate and get the patient to participate. It gives you 20 case studies there. And then evidence on the quality improvements and the cost savings. Moving on to our next slide, which is slide number 39, we've got some toolkits and items available for medical homes that are free and available for everybody. There's an animated video that is parked on our website that providers can put on their website or show in their waiting rooms. We have it in English and Spanish, about 4 minutes. It's animated. It describes what a medical home is. There's the deep dive brochure on patient-centered medical home. There's an 800 number. We have a partnership with Merck where you can order those and have them shipped at no cost, as many as you want. And there are other guides and toolkits and brochures that are available for practices. So we're going to move on to slide number 40. Just want to stress that our calendar, all of our activities, everything's available on our website. You can go right online and sign up to be a user, sign up to join the collaborative. We have general membership at no cost, so you should certainly take advantage of that and start receiving our information. And then our next slide here highlights our upcoming events. Our next conference, which will be probably well over 500 people here in DC, is October the 21st. We'll have a networking cocktail party the evening before. We do allow a small number of selected sponsors and exhibitors at our conferences. Just started doing that this year. And we do waive the fee for government employees. Now it costs $350, and we have 2 room blocks with good rates at hotels in DC. So that ends the portion of our formal presentation. So we'll move on to the questions now and see if there are any questions. I'm used to doing this orally, but we'll do the written questions. And Lauren Vandegrift, our webmaster, is going to help me with these.
Hi. Thanks very much, Joanna. Yeah, there are just a few questions here. Remember, you can submit your question in the question box on your little control panel there, and we will try and get to you. The first question is, what are the relationships between active medical home projects and the use of HIEs?
Okay, what are the relationships between active medical home projects and health information technology? Is that correct?
And HIEs, yeah.
HIEs, okay. So, well, I'm assuming that they mean just health information technology.
Exchanges.
Okay,
Yeah.
All right, that's what that stands for. Well, medical homes all are very much involved in health information technology, and I can tell you there is a problem. If you think back to the stimulus money, and every primary care physician in America will be seeing about roughly $44,000 from Medicare to implement their health information technology and their medical records, electronic medical records. And those that are more participating with Medicaid will see roughly, 64,000 over a number of years, roughly like a 3-year program. And there was stimulus money that went out to all the states to help the primary care physicians only and go to them and help them select a vendor for health information technology. Now, what have we done? Some of the things that we've done, we have made sure that meaningful use fits in perfectly with the medical home, so you don't have to worry about a whole other set of regulations and requirements. So if you are a medical home, meaningful use is going to be taken care of. We have put out a guide on the recommended types of decision support tools on the IT side that you should have in place. We have a guide on participatory engagement IT tools that you can use to get your patients to participate, so that your pay-for-performance piece and your HEDIS measures and your other best practices, come in nicely, and you don't have any issues there on getting the performance check. We have a guide called Meaningful Connection that outlines about 20 case studies and what did their medical homes and what did they do to get their IT in place. And we're vendor neutral, of course, but we specifically let them talk about the vendors that they use. In October, we'll have a new guide on the IT that you would need to be an accountable care organization, and we're looking at the usability of the IT. What is, where do you get the value for the dollar on the IT side? So I think that pretty much takes care of the IT question. Usually the minimum IT requirement would be the electronic patient registry.
Right. And it was referring also partially to the health information exchange, like state-by-state exchange, and as opposed to just the HIT portion. But that's terrific.
Oh, okay. All right. So the exchanges, yes. Well, of course, we work very closely with them in tandem.
Exactly. Excellent. All right. Is there any data on the cost in resources and dollars in modifying practices to a medical home?
Okay. Very good question. Well, I would say that the answer is that it really ranges. Some of the medical homes already had a lot of these systems in place and processes in place, so they only had to maybe add one or two or tweak. Some I have seen, some to just kind of plan on doing it by just sort of doing hard work and not put out a lot of new money or they've been able to save money by some efficiencies that they had it and didn't know about. Many of the implementation programs, let the medical homes use their monthly care coordination fees to help them fund the transformation process for a period of time. It might be 6 months, 12 months, 18 months, where they get the fees, and then at the end of the time period, they need to be a recognized medical home. So I wish I had a better answer for that, but I can't say it costs $20,000 or $40,000 or $5,000 or $10,000 because there's such a range, and there are medical homes around the U.S. that have been able to get their recognition without doing hardly any additional expenditures, and then others have put in some elaborate systems. Okay, so the next question.
Going along with that slightly, is there any data of the cost per patient per month versus the incentive per patient per month?
Okay, the cost versus the incentive. Well, if you look at maybe I think the question is probably getting at the profitability or the net that the medical home provider should expect. Now, on the incentive side, you're looking at the monthly care coordination fee plus the traditional office visit fee for service type plus the pay for performance. You have to add all of that up. And then the cost, well, the cost generally goes up a little to offer a medical home, versus what they were before, unless you're able to, find some efficiencies that maybe perhaps you didn't know about. But there should be a net financial incentive for the medical home provider. And, we've run across some of the lower paid ones that are netting $20,000 a year up to some of the higher paid ones that are talking about something in the range of $120,000. So I think that answers that question generally. I mean, that is information that we want to track. And of course, you have to really kind of get into people's personal business. Our payment reform task force, would love to have some more of that data. But there wouldn't be already 40 operating successful medical homes if they were, doing that at a loss. But you see 4 improvements, 4 categories that improve, and clinician morale is one of them, and the patient satisfaction rates go up, the health outcomes, quality improvements, and the cost savings. So Great. The next question?
Great. Yep. The next question, actually just a quick one, is where do the disease management companies centered around laboratory testing, does that fit into the PCMH model?
Okay. Well, the disease management companies that center around lab testing, well, they fit in, of course, very importantly in the medical home model. If you think about when I described what is a medical home, and under the decision support category, it's required that the medical home offer best practices and disease management and have easy access to their labs and test results, and implement it right away, and reminders, and the list goes on. So the primary care provider will have to have those tools in place. And, of course, they're receiving these additional payments, the monthly care coordination fee payment per patient per month, risk-adjusted, and some pay for performance. So I see it as a very important industry, a growing industry, but perhaps maybe their clients have changed in the past. They might have been more payers and employers, and now it would be basically all the providers that will be offering the medical home, which could easily top 400,000 of them as we go along here.
Great. And just to make a quick note to people that are asking, this slide is always available on the website under General Presentations under the Who We Are tab in the sidebar. And also this video, but it'll also have the slides, will be available later on today to watch or to pass around to people. Now, the next question is, what software tools are available to support PCMH to improve communication and coordination?
All right. Well, that's a very good question. Seems to be a group that's very interested in IT today. So, we talk about the usability and the operability. We don't really, talk about specific vendors, but we have a number of guides that detail the software tools that are currently available. Like, for example, I talked about our guide on decision support tools that you would need to have in place. So that generally talks about the type of decision support tools that you would need to have in place, but doesn't actually list the names of companies. Now, we do have one guide that does talk about actual vendors that medical homes are using. So we did a big survey of medical homes. We looked for best practices, picked out 20 case studies, and then they detailed, how they did it and which IT vendors they're using for what. We have the guide on IT tools for participatory engagement, and then we're coming out with the new guide on the IT tools that will most likely, be vendor specific also by outlining some case studies on how to put your IT in place to be an accountable care organization. So are there any more questions, Lauren?
There are quite a few. Some of them are kind of variants on each other. But as we're just for time's sake, I would ask you about one more just to continue in the IT vein. What are practices doing to digitize their existing paper records to reach meaningful use, or are they just keeping the paper files and then using the EMR for future patients? What have you seen?
Okay, well, it's a variety. Some are going back and putting everything into an electronic system, and some are just starting fresh. We've seen it work both ways, but by no means do people feel like they have to go back.
There's no way to do it.
And then you can actually be a medical home and be a paper practice, but it certainly helps to move in that direction. And there's quite a bit of stimulus money for primary care providers and other physicians and hospitals to move in the IT arena. I talked about that earlier, the $44,000 through Medicare and the $64,000 through Medicaid.
Great. Are patient adherence programs of value to the PCMH model?
Well, participatory engagement is extremely important, and patient adherence programs are important. It's sort of a whole category that you need to activate and engage your patients and give them treatment plans and have follow-up reminders and access to their medical records and counseling with self-care. And we also have a whole guide on how to do that so it doesn't become something that seems overwhelming, where you can get good results so you're not at the mercy of sort of non-compliant patients, that you did this and that item, therefore if they don't comply at that point, then you're not really responsible for that particular patient's non-compliance. So that's all worked into the model, but their participatory engagement of the patient on the IT side has come a long way in just the last couple of years. And like I mentioned, we have a whole toolkit on that, on the participatory engagement IT side, on our website, free and available.
Excellent. And there's a lot of questions about cost per patient and then also Medicare. So just to kind of try and pick a couple of the most poignant ones. As far as healthcare reform, Medicaid reimbursement for primary care will be 100% of Medicare. Will this also apply to managed Medicaid programs?
Well, it applies to all of Medicaid. All primary care Medicaid payments for the years 2013 and 2014 have to pay at the minimum rate for office visits, etc., the Medicare level for primary care services only.
Excellent. Okay. And then is transitional care addressed in the PCMH model? And if so, do you have resources that address transition care?
Well, in the patient-centered medical home model, since the core piece is that the medical home is offering care coordination throughout the whole system, the behavioral health side and the physical health side, transitions in care is certainly covered and required to be covered. But then if you move over to the accountable care organization model, of course it's covered, throughout the whole medical neighborhood for examples that would not perhaps touch on the medical home model. There are patients that would be kind of operating from point A to point B, and perhaps their medical home wouldn't be included. But some of the ones that we think about, of course, are the readmission rates for hospitals, tying in long-term care, home care, monitoring devices. All of that is very much something that we think about and worry about and study.
Excellent. I think that's kind of the main areas. There's some questions in the like incentive range. People are curious about the incentive range based on what you said, and if, like, based on ongoing pilots, do we know where our cost per patient for providing PCMH services is at the moment, and kind of looking for some more numbers. But otherwise, I think that's a pretty good cross-section of questions, unless anyone has any other ones.
Okay. Well, we gave some specific examples of what the cost was per patient before they went to the medical home and then after, or those that are in the medical home versus the patients that are out of the medical home. And we have many more examples on our website. There are probably about 60 implementation programs that have reported their data. And, of course, that's one thing that they generally report would be the cost of care for the patient outside of the medical home and inside the medical home, so you can do the comparison.
Great. Yeah, no, I think that's a pretty good cross-section of questions. And just I'll let you wrap it up, but this will be available on the website later today, along with the slides, which are always available and updated every single month for anyone that's interested in sharing.
Okay. Well, the last comment that I want to make has to do with that we're here and available. Any presentations that you need in person, webinar format, audio, for any group, just contact us. You see the email here, and there's my cell phone also. So just email me and we can set it up. And if you are interested in starting an implementation program in your area, we can certainly help you with that. We have our own travel budget. We do technical assistance. We don't charge for the things that we do. So just call us with any question, email us, and we will do our best to help you, point you in the right direction, or send you a guide that has already been written on that. And I would strongly encourage everybody to, if you haven't already joined, go to our website and just sign up and become a member and start getting our materials. And certainly come and meet with all of us on October the 21st. It's nice to meet everybody in person, and things are very well attended. We're looking forward to the future. Okay, so we'll let everybody go, and we're here to help you. Thank you. Goodbye.